my name's Audrey Kresmer. I am part of the Kindbody team here, and you'll see my name listed both on the side but also in the chat as Kindbody Audrey. So pleased to have you all with us today and really excited to walk you through today's Kindbody Fertility 101, led by Dr. Meredith Brower. I'll go ahead and turn it over to Dr. Meredith Brower to go ahead and introduce herself.
Hi, thank you again, everybody, for joining us. My name is Dr. Meredith Brower. I am one of the reproductive endocrinology specialists at Kindbody, and I'm based here in our Los Angeles office in Santa Monica. And yeah, I'm part of this wonderful Kindbody team. And what I'm going to do today, I think Audrey's going to maybe walk you through a little logistics, but I'm going to sort of introduce you to Kindbody and who we are and what we do, and then sort of give just some basic information about all things fertility, and answer and take the opportunity to answer any questions you might have. So, Audrey, did you want to?
Yes, absolutely. No worries. I also wanted to introduce you to Kindbody Tracy.
Hi, everyone. Nice to meet you. We're so happy to have you here today and to join us and learn a little bit more about Kindbody. So thank you for joining us.
And like Dr. Brower said, I'll go ahead and just kick things off and tell you a little bit of the logistics behind it and then turn the reins over to her. So like I said at the beginning, welcome to Kindbody and welcome to our Fertility 101 today. So really at the core of Kindbody is we are on a mission to make fertility and family building accessible and affordable for all. And so a big part of that is also partnering with employers and companies like the ones that all of you work for. And so we're thrilled to have you here today because your company has provided Kindbody to you as a benefits package. And Dr. Meredith Brower is going to walk you through not only what options are available to you, but also provide that education with respect to how fertility works, what options are out there, and then we'll end it with how you can actually book an appointment and take advantage of your benefit if you'd like to. So Dr. Meredith, if you could just go to the next slide. Like I said before, we're thrilled to have you all with us today. Your company really found it so important to provide very accessible and affordable coverage for you when it comes to fertility and family building needs. Here at Kindbody, we cover the full suite of services, and Dr. Meredith Brower will go through that in just one moment. But today we are here for you. And so part of that, you may have questions when it comes to your clinical care or when it may come to the actual coverage that you have provided to you. So you have myself, again, my name in the chat will be Kindbody Audrey. Any question you have with respect to your coverage and with respect to the benefit that you have for your company, feel free to chat me and I will look up your coverage or be able to answer any questions you may have. We have members joining us from companies, all different companies, so everyone's coverage is a little bit unique. So feel free to just chat at me and I'll be happy to go through and address your specific coverage. If you have any clinical questions, of course, Dr. Meredith Brower will address all questions at the end, but you can also float those over to Kindbody Tracy and she'll be happy to handle those or address them or save them for the end for Dr. Meredith Brower to speak to at the broader group. So with that, we would love to see where everybody is joining from. So I'm going to turn it over to Dr. Meredith Brower, but in the chat, we would love to see where are you joining us from. I'm tuning in from New York City. So I'm on the East Coast, and I know Dr. Meredith Brower is in beautiful and sunny LA, but would love to see where all of you are from as well. So go ahead, Dr. Meredith Brower, I'll turn it over to you.
Thanks, Audrey. Appreciate it. So, as we mentioned at the beginning, so at Kindbody we provide sort of the full spectrum of fertility care. So that includes everything from people who are about to start trying to get pregnant, people who have actively been trying to get pregnant and have had a hard time getting pregnant, and those who are interested in preserving fertility. So we offer sort of full spectrum and really everything from education to sort of your most involved treatments. We do all of that here. In most of our clinics, we provide some basic gynecologic services, and then we also provide support services, which is, I think, something else that makes us unique. So in addition to providing the medical services, we have our own nutritionists, we have our own counselors, and we are sort of cognizant of sort of supporting a more holistic version of care, regardless of where you are in the journey. And we, our part of our goal and mission is to provide that for all of our patients. We also provide LGBTQ services and all the full spectrum of fertility care that involves family building for that population of patients as well. Again, we are open. Even now, I guess it's becoming more relevant here in California than it was a couple of weeks ago, but we did reopen our clinics as soon as the state of California and the city of Los Angeles deemed it safe to do so. There are extra precautions that we're taking in the clinic, but I think we have overall felt like they're working, and we're keeping the clinics a safe environment to receive care. So, as I mentioned, a lot of what we do here is education. And as females, as males, as individuals, we mostly receive education on how not to get pregnant. So that's not confusing for most of us, right? Most of us have been given a lot of information on how to prevent pregnancy, and there's a lot less information on fertility, how to get pregnant, aging and fertility, what are factors that impact fertility. And so a lot of what we do here, regardless of where you are in your journey or what your reproductive goals are, we are sort of committed to providing people with that education. And again, that's a huge part of our mission as well. And we always say you're never too young and you're never too old to learn about this, about your fertility, about fertility in general, and those things I mentioned about the various things that can impact fertility. So we encourage everybody to at least get the information, regardless of where you're at, regardless of what your reproductive goals are. So the next thing I want to do is just sort of walk you through what are the things that we can test, what is a fertility evaluation, and in order to understand that, it's important to think about what the building blocks are to create a pregnancy. And this may seem obvious or it may not, but the basic building blocks are the sperm, the eggs, and the house, the uterus, and the fallopian tubes, which is where ultimately a pregnancy would grow. And so we're going to talk about the evaluation and each of these components individually. So I'll start with the eggs. And so for us females, we are born with all the eggs we're ever going to have, right? We never generate any new eggs throughout the course of our lives. And actually the most eggs you ever have is before you're born. Okay, you actually lose eggs from the time you're 20 weeks gestation to the time you're born. And then throughout the course of our lives, we continue to lose eggs every month. It's not fair. Egg production is not a regenerative process, but this is sort of at the heart of aging and fertility for females, is that, again, you're just born with these eggs and you don't make any new eggs throughout the course of our lives. So two things happen to those eggs over time. We lose them. That's egg quantity. As it said in the last slide, we probably lose about 1,000 eggs per month. And again, we're not making new ones. And then the other thing that happens is that the quality of the eggs decline with age as well. So just like any other cell in our body, eggs are also declining in quality. And as we get older, the percentage of eggs that are actually normal declines. And that's really often what's at the heart of aging and infertility. There are other things that can impact egg quality, which I'll mention in just a second. But certainly age tends to be the most important factor. Certain other lifestyle modifiers, smoking cigarettes, having marijuana use, obesity can also negatively impact the quality of the eggs as well. So, again, sort of age is the most important predictor of egg quality. And there's actually frustratingly no good way to measure it. So we can sort of say this is the average egg quality for somebody's your age, but there's never any way to directly test the quality of the eggs. 35. So this is a number that gets thrown out all the time. People walk into my clinic every day, and people have an awareness of this, even if they don't know physiologically what's going on. People walk into the clinic every day. I would say 75% of the time, a female, the first thing she tells me, I'll say, what brings you in today? I'm 33, I'm 35, I'm 38, I'm 42. The first thing they tell me is their age, which say, okay, I say you already have some awareness that what I've just described to you is happening. And this number 35 that gets thrown around is some magic number where there's something happens after the age of 35. And it's not totally true. It's a little bit arbitrary, because this whole decline in the quantity and qualities is a gradual process. So it's true that if you look at populations of women, probably not much happens, certainly in terms of the loss of quality before the age of 32. And then after 35, there is some gradual decline in quality. And then certainly after 40, it tends to happen more dramatically. But so that 35 number is often out there and referenced as the time where you'll start to see in populations of people a decline in the quality of the eggs. Sperm, again, I guess I should get back, and we're going to talk about this in a second. I did mention that you can't test the quality of the eggs. You can test egg quantity. And in a second, when we talk about what happens in a fertility evaluation, we'll talk about the different ways to do that. So although they are separate and you can't test quality, you can test quantity, and that can give us some important information about your fertility. For men, we can also assess the sperm. Just as we can assess egg numbers, we can assess sperm numbers too, and it involves essentially for a male to provide an ejaculated sperm specimen. It's looked at under the microscope, and we can look at how much sperm is there, what percentage of the sperm are moving, and what percentage are shaped normally, and this can also give some information about male fertility. As you can see here, there is some overlap between fertile and subfertile men in terms of these parameters, but it can give an initial assessment if it's, grossly abnormal or if it's grossly above normal. So again, quality of the sperm is harder to test, just like the quality of the eggs are harder to test, but quantity is a testable entity. Sperm production is a little bit different than egg production. Men can actually regenerate new sperm cells throughout the course of their lives. So there are stem cells in the testicle that generate new sperm all the time. So the impact of aging on male fertility tends to happen a little bit later in men in general than it does for females because it's a regenerative process. The stem cells do eventually get tired, so there does tend to be some impact of aging on male fertility as well. As those stem cells get tired, the regeneration of sperm producing cells tends to be less efficient with age. And then the last thing, I don't have a slide here to talk about, is just the uterus and tubes. So in couples who are actively trying and not having any success, we also evaluate to make sure the fallopian tubes are open and that the uterus is a sort of a hospitable place for a pregnancy to implant. There are many things that probably impact fertility, age being one of the most important for men and women. But as I mentioned, we do sort of try to take a more holistic approach, and there are other things that can negatively impact fertility. I mentioned some of the most important ones so far: obesity, any sort of substance use. Those are very negative for fertility. There are other things that are positive for fertility. There's supplements that we recommend that are often antioxidants that have been shown to be helpful for both egg and sperm quality. And again, we provide those support services through our nutritionists, through our mental health specialists, and our acupuncturists as well. So that's always part of our education. I think that in addition to understanding the building blocks, having a basic understanding of what's happening in a normal menstrual cycle for a female is important for everything we do. It's important for those who are about to get pregnant. It's important for preservation and for all of our treatment, because it's sort of the premise of everything we do here. And so some people know how this works and some people don't, but in an ovulating female, so in a female who has a regular period every month, she starts with her ovaries. You can see this picture. This is our picture of a beautiful picture of a uterus and an ovary here. So you can see this ovary, those little circles are supposed to be follicles. And within each of those follicles is a microscopic resting egg. So at the beginning of a menstrual cycle for any female, who's still ovulating. There's a microscopic egg in each of those follicles. At the time of ovulation, so you start with a group of eggs or follicles. At the time of ovulation, one of these follicles gets really big and it releases a mature egg. Now, if you're trying to prevent pregnancy, you want to not have sex at that time. If you're trying to get pregnant, that's when you are trying to have sex in order for a pregnancy to occur. All of those follicles or eggs that weren't chosen that month end up dying. And that's part of what's contributing to this egg loss that occurs in the background of our lives all the time. So that's kind of the basic premise of a normal ovulation. And it's really the basis for everything that we do or everything that happens here. So understanding when this ovulation is occurring is important for understanding how to conceive. So again, as I mentioned, a lot of the people who are coming into the clinic are just about to try to get pregnant and just want some information on how to do exactly this. And we provide a lot of information about, okay, if we know this is the length of your cycle, this is probably when you're ovulating, this is how to track. So there's a lot of different ways to track, and this is helping people to understand when this fertile window is so they can have sex in the appropriate window in order to conceive. We counsel people on how to use ovulation predictor kits if that's something that they've not done before, again, to sort of understand in more detail when this ovulation is actually occurring. So again, I really do think kind of getting into this, you know, part of what we do is when we first meet with you. So the first step always is gathering the information for us to understand, for you, if once you book a consultation, for us to understand who you are and what your reproductive goals are. So, you know, where are you in your journey? What are your goals? And that really helps us to come up with sort of educational information, as well as a plan that's specific to you for you to get from point A to point B, whatever point A and point B are for you as an individual or as a couple if you have a partner. So again, when you come in, and again, right now we can do these consultations in the office. We are doing that. Again, we're masked. You'll never see my face ever again if you do come to the office because I'm fully masked. Or we can do them virtually, which actually has been really nice. When we do virtual consultations, not only do we get to see each other's faces, but oftentimes if you are in a relationship, both partners are there. And so I think that's kind of helpful. And if you choose to do your consultation virtually, typically what happens then is you come in for a follow-up for a very quick ultrasound and blood work, which is sort of the second piece of the information. And then we follow up after that to talk about everything together. So again, the consultation can be in person or virtually. And the goals of the consultation is for us to understand, get all your history, understand who you are, and put a plan together based on what your personal reproductive goals are. As I mentioned, so if you do the consultation in person, we'll do the ultrasound and the whatever necessary blood work the day of the consultation. And if you choose to do it virtually, we just get you in the schedule, and it takes probably 15 minutes for the follow-up to come in for an ultrasound and blood. And then the doctor will typically call you once everything's back to review and come up, sort of finalize next steps. This blood work that we're doing involves this measuring of the egg quantity. So oftentimes what we're doing is checking on egg numbers or egg quantity. As I had previously mentioned, that's the thing that we can test for the eggs. Egg quantity can be measured a couple of ways. We measure it with a follicle count on ultrasound. So remember, I just showed you that picture with those follicles. That's what if you're a female, your ovaries will look like that too. And we'll actually count up those resting follicles to get a sense of what your group is like. What is your group of eggs each month? And the group of eggs you get each month isn't the total number of eggs left in your ovary. So you can see this person here had a follicle count of 7. She doesn't have 7 eggs left. She got 7 eggs in that group. And that means, you know, people with big groups tend to have more eggs than people with small groups. The blood work that you do most commonly is a blood test called AMH, which is also a measure of egg numbers. So we kind of measure it in at least 2 ways to kind of get a sense of what your egg quantity is. The other blood work that we're often doing is just some basic health measuring, some basic preconception testing, especially in an individual who's planning to be pregnant, checking on thyroid, vitamin D, making sure there's no anemia. So checking some other things that are relevant to optimizing pregnancy. I think what I'll do, so that's kind of what happens largely at an assessment. The semen analyses are booked at a different time. They don't happen at the time of assessment. A male would give you all the information that you would need to book an appointment in order to give a specimen for a semen analysis. So the last thing, or maybe second to last thing I want to talk about is just treatment. So again, it always starts with an assessment, and then after assessment, you may choose to engage in some form of treatment. And so I want to walk you through what these various treatment options are today. The first two options that I have listed there are focused on preservation, so not actively trying to get pregnant, but preserving fertility. And then we'll go over what the treatments are for individuals or couples who are planning to be pregnant. So starting with preservation, preservation of fertility comes in two forms, either freezing eggs or freezing embryos. So regardless if you're freezing eggs or freezing embryos, the whole idea behind that is you're just pressing pause, right? So I've already mentioned that the quality and quantity of eggs decline with time. And so the idea behind preservation is we say, okay, well, I'm going to take my current eggs, the quality of which is based on my current age, and I'm going to freeze them. And maybe I'll freeze them as eggs, and maybe I'll freeze them as embryos. I'll talk about the difference in just a second. But the quality of this insurance policy will be based on my current age and not the age at which I use the eggs or the embryos. So in this process, again, I'm going to actually skip this slide here. So what we do in the egg or embryo freezing process is that we stimulate as many eggs as safely possible to grow at one time. So again, let's remember what I said about the process of ovulation. In a typical cycle where you don't take any medications at all, you start with your group of eggs, your body releases grows one big mature follicle and releases one egg, and all the others die. Okay. So when we do a fertility preservation or any kind of cycle where we're stimulating the ovaries, we try to prevent that death. Okay. We try to stimulate as many of the eggs that are in that group as possible to grow. We do that with injections that you administer in your tummy. We teach you how to use them. And you take those injections for an average of 8 to 12 days. And the purpose of those is to get as many of those eggs to grow as possible at one time. Okay. So again, I think this is interesting. Fertility care is opportunistic. So a very common question I get is, well, if you get 10 eggs or 12 eggs from me at a time, am I worse off? Am I now even down even further on my egg count? And the answer is no. And the reason that is because we are being opportunistic. What we're doing is we're taking that group that you get at the beginning of the month and trying to get as many to grow and as few to die as possible, as opposed to a natural cycle where you get one growing and everybody dying. So we're sort of just rescuing as many as possible from death and trying to capture as many eggs in 1 month as possible. So again, I mentioned that what those injections are doing, and here's this lovely picture of Hina, who's the most wonderful person in the world, and she makes these videos so that you can watch, and then we obviously teach you how to use them as well. And then a lot of our patients will actually sort of have Hina up in the background as they're doing their injections each night, just for comfort, to make sure they're doing them correctly. And again, the purpose of those shots, these hormones that you're taking, is to stimulate multiple eggs to grow from the ovary at one time. This is a sample calendar here. As I mentioned, the whole process takes about 10 to 14 days, and that includes both the stimulation of the ovaries as well as the egg retrieval. So at the end, so during this time where you're taking these injections, and as I mentioned, you're on them for an average of 8 to 12 days, we monitor you closely. So these are supposed to, if you come into the clinic, you actually get this calendar, but these are ultrasounds. So once you start your injections, you come in every couple of days for an ultrasound, and what we're monitoring is how many eggs are developing and when to take them out. And then we have to determine the best day to do that. So because everybody needs a different amount of time for the injections, there's a whole week where potentially that egg retrieval will occur. And once you start, we kind of get a better sense of when that is. And it, again, it's really about a 10 to 14 day process in total, from the time you start the injections to the day of the egg retrieval where the eggs come out. So the egg retrieval is the taking of the eggs from the ovary, and what happens, it's a small procedure that occurs at the site of the embryology lab. You get anesthesia, so it's a sort of a twilight sedation, a heavy twilight sedation. You're still breathing for yourself, but you don't feel anything and you don't remember anything. And while you're sleeping, your doctor will sort of pass a needle through the wall of the vagina and into the ovary and take an egg out of each of those follicles that have developed. And then the eggs, there's actually a window in the wall that gets passed. So the eggs get passed directly into the embryology lab. And then there are two options for those eggs. Okay, you can freeze eggs, all right? Or that same day, if you have a sperm source and you want to make an embryo, you can fertilize the eggs and make an embryo. Again, both methods are, are for here as I'm talking about them now, are for preservation. Freezing eggs for a female allows her to use those eggs however she wants in the future. She's not committed to any sperm source, and in 2 years or 10 years or 5 years or 15 years, she can use them with any sperm source that she wants. And at that time, when she's ready to use them, if she ever is, she can thaw the eggs, fertilize them with her preferred sperm source, create an embryo that ultimately is transferred into her uterus. And individuals or couples choosing to freeze embryos, the egg is fertilized the same day that the egg is retrieved, okay? Then the embryo at that time will develop. We'll get to see, do the eggs fertilize? Do the eggs develop? Do they develop into embryos? You even have the option to genetically test the embryos. So one is not better than the other. So embryo freezing isn't necessarily better than egg freezing. It's just that you get a lot more information about what your actual insurance policy is when you create an embryo, because you get that information now. Does fertilization occur? Does embryo development occur? How do the embryos look? Are they genetically normal embryos? And ultimately, if you freeze eggs and you use them, you get that information, you just don't get it now. So the downside to the freezing of the eggs isn't that it's worse, it's just that you have less information. Because even when you take the eggs out, you still can't tell about quality, right? It's crazy, right? There's even when you take them out and looking at them, you can't necessarily tell if they're good or poor quality eggs. But again, the upside is that you can use them however you want in the future. Whether you freeze eggs or freeze embryos, they're stored at the site of the embryology lab. And another common question I get is, well, how long can you store them? Indefinitely. We don't really, there's no evidence that the quality of those decline over a 10 or 15, 20-year period. Usually what happens is someone ages out of being pregnant before anything happens to those eggs or embryos. And as I mentioned, if you did ultimately freeze eggs, then in the future to use them, you would have to fertilize them and turn them into embryos so that embryo could be transferred into the uterus. Infertility. So again, the other thing that we do here, one of the other things is take care of couples who are having a hard time getting pregnant. Infertility is sort of classically or academically defined as the inability of a couple to get pregnant after a full year of trying with regular cycles and appropriately timed intercourse. With that being said, so 85% of couples will conceive within the first year of trying, and that's where that definition comes from. With that being said, in couples who are where the female is 35 or older, or if there are other risk factors for infertility, so exposures, other things, advanced paternal age, irregular cycles, history of surgery in the pelvis, anything else that might also be a risk factor for fertility, we recommend being evaluated, or not just we, everyone, the American Society of Reproductive Medicine recommends being evaluated at 6 months. At Kindbody, we think you should get evaluated whenever you want to be evaluated, because just because you do an evaluation for information doesn't mean you need to initiate treatment. So those are kind of formal recommendations. We always encourage everybody to get information whenever they feel like they want the information. And you can see here some numbers here. 1 out of 8 couples experience infertility, and a third of the time there is some male factor infertility involved. So I think often as females, we kind of assume that it's our fault, or most females I see assume that somehow it's their fault, but it does of course take two to tango. Again, treatment options for fertility can involve everything from just helping a female ovulate if she's not ovulating on her own. We do what we call intrauterine insemination cycles. So sometimes the most appropriate treatment is stimulating the ovary to make 2 eggs, more than 1 egg at a time, but not as many as possible as we do with IVF or egg freezing. And then taking the sperm and putting it right inside the uterus at the time of ovulation. So that's often what's happening when we do these insemination cycles. IVF. IVF is one of our more aggressive treatments. IVF is exactly what I described when we were talking about embryo freezing. The only difference is that ultimately the embryo would be transferred to the uterus. So in preservation, the embryos are frozen and they aren't transferred into the uterus until a later time if necessary. And when you do IVF to actively conceive, the steps are exactly the same. The injections are the same. The calendar is similar. The timeline is similar. The concept is the same. We're stimulating those ovaries to make lots of eggs. Eggs come out. Egg and sperm are placed together, but now we actually do an embryo transfer. So then if we have embryos, which hopefully we do, the whole thing is followed up by an embryo transfer where an embryo can be placed back into a uterus. And then 9 days later, we find out if you're pregnant. So that's kind of the main difference there, but that is also sort of in our bag of tricks for treatment options. We also have other methods of family building that we do. Some patients need egg donors for whatever reasons, and there's many reasons to need one. Sperm donors, as well as gestational carriers, which is using somebody else's uterus to carry a pregnancy. So we don't need to necessarily, I don't think we'll go into all of these options in great detail today, but they are things that we do quite commonly here in our clinics. And I think, again, so kind of, if you are interested, we sort of, no matter where you are in your journey, if you're just thinking about getting pregnant or you're not thinking about getting pregnant and you just want to know more about your body, or if you're interested in preservation, or if you've been trying to get pregnant for a year, or if you've had 5 miscarriages and you've seen 3 fertility doctors, you could be anywhere when you step into your office, and we would hopefully be able to take care of you and help you move forward with whatever that journey is that you're embarking on. I think that takes me back to Audrey, who is going to talk you through a little bit more, I think, about the packages. And then if there are any questions, I'm happy to answer any questions that people might have.
Perfect. And thank you so much, Dr. Meredith Brower. I'll go ahead and just kind of bring us all home with respect to the benefits package and how you can actually book an appointment, but would love to go back to questions right after that. So Dr. Meredith Brower or myself or the team can address any and all questions that have come in throughout the super informative presentation that Dr. Meredith Brower just walked us through. And so, like I started at the beginning of this call, you all have Kindbody provided to you by your company, which is an incredibly generous benefit. Again, it's a testament to the company that you work for and the company that you choose to work for. They found that fertility and family building really should be accessible for all. And so they've designed packages for you so that you can take full advantage of everything that Dr. Meredith Brower just talked about. So everything from booking an assessment just to figure out what is going on in my body, or what does my fertility look like today, so that you can sit down with the doctor and based on your clinical information, but also just your future goals with respect to family building, can really design that plan that is personalized for you and proactive or reactive, depending on where you're at in your family building journey, can really personalize that for you. So like I said at the beginning, more than happy to address any questions before we wrap up this call, but also wanted to provide access to employee benefits at kindbody.com. That goes directly to our care navigation team, who can route you to the clinical team or help you book an appointment or answer any questions on coverage at any time. So anytime you have a question about your benefit or just where to get started or what to do, you can reach out at employee benefits at kindbody.com. And Dr. Brower, if you wouldn't mind just going over to the next slide, I just wanted to show everybody how they can actually book an appointment. And so it's really simple and really easy. And part of what Dr. Meredith Brower talked about was the actual journey and how Kindbody can provide the additional touch points with our clinical team, but also we have our own patient portal. And so what you can do to book an appointment is just head over to kindbody.com/members, where you're going to create an account with Kindbody. You all have been provided a code from your company, so you can either reach out to HR or just drop us a note at employeebenefits@kindbody.com if you don't know what that code would be, and we'll be happy to provide that to you. But that code is custom, again, to the coverage provided to you by your company. So you're going to book using the code that was provided for your company to kick off your journey. You're going to create your Kindbody account using your work email address. Again, nothing clinical, nothing personal with respect to your health will be sent to you at that work email address. It's really just for our end, as well as your employer, to determine eligibility, so that we can, again, ensure that we're providing you the right coverage and the most accurate coverage for you. So it's as easy as that. You just head over to kindbody.com/members. You enter the code provided to you by your company, and you can book that assessment or begin a cycle, or book one of those wellness services like Dr. Meredith Brower was talking about, from the mental health to the nutrition, you name it. We are here for you, and we really are excited to work with all of you, regardless if you're ready for a family today, tomorrow, or 10 years from now. We're confident that we here at Kindbody can really be that one-stop shop for you. And so in addition to the fertility and the supplemental services, we also accept all major insurance carriers. So you can even come to see Dr. Meredith Brower or the teams in the other markets with respect to gynecology needs or anything like that. And so with that, I'm going to go ahead and bring Kindbody Tracy back in, because I know she got some questions while Dr. Meredith was presenting. And so we'll go ahead and transition back to questions. So any and all questions, feel free to send them either privately to myself or Tracy, or to the group, and we'll address those now.
Yeah, no, I got some great questions. Dr. Brower, someone wanted to know that if you're on birth control, are you still losing eggs every month? Oh, she's muted, unfortunately.
There we go.
Oh, she's still. Meredith, you're still muted. I'm sorry. We'll get you. There you go.
There you go.
There we go. That's a really, really good question. And sadly, yes. Sadly, we are losing eggs. So this process of a group of eggs coming up and being lost happens. Because right, you're right. When you're on birth control pills, you're not ovulating. So the difference when you're on birth control pills is you get that group and you never ovulate one. You just lose the whole group. And so that process of ovarian loss, unfortunately, is going on if you're on birth control pills, if you have an IUD, if you're pregnant, if you're just not ovulating. It's sort of ongoing in the background, no matter what's going on. And so interestingly, being on birth control pills, it doesn't have any either negative or positive impact on long-term fertility, because you could kind of think about it either way, but it has been shown not to. The one thing that is interesting about birth control pills is that the purpose of the birth control pills is to keep the ovaries quiet, right? To prevent them from ovulating. So sometimes when people come in for an evaluation to sort of see what their egg count is, it can appear falsely low on the birth control pills because the ovaries are quiet from the birth control pills. Typically, if that is the case, that once that individual stops the birth control pills, you'll see a rebound. The follicle counts come back, the AMH levels go up. So again, it's not having any permanent damage, but it can impact your assessment. It can impact what we sort of ultimately think the egg numbers are at that given moment, because they may be falsely suppressed from the pills. It's a really good question.
And I have a few more related to birth control and IUDs, but we just had another question in the chat asking about genetic screening. Do we offer genetic screening, and then specifically with Batten disease, and talk a little bit about that?
Yes, so we do what we call genetic carrier screening. So as part of sort of this preconception testing that we do for anybody interested in either creating embryos for preservation or trying to get pregnant, we offer what we call genetic carrier screening, which checks to see if an individual carries mutations for a whole panel of diseases. The panel that we most typically use has 283 diseases on it. And oftentimes these are what we call autosomal recessive diseases, meaning that you could carry a mutation and never know because you need two mutations to actually have the disease. But it's relevant because if you're going to procreate with somebody who carries a mutation for the same disease, then you could have an affected child. Now, I don't know for sure if Batten disease is on that panel. If you have a disease, if you carry a mutation for a disease, something like that you actually have the disease, even if it's not on that panel, we can arrange for screening of embryos. So we often see people who are carriers of things like BRCA. That's an autosomal dominant disorder where you only have to have one mutation to actually have disease. Huntington's disease, we've Lynch syndrome, so various cancer syndromes where you may carry it, and then if you chose, you say, hey, I want to make sure my offspring don't also have this mutation. The process is a little bit different, but we can certainly arrange or help you to create embryos that are screened for that disease that you're trying to screen out of your family.
Awesome. And then, so our next question is, if you are on birth control or on an IUD, can you still get properly screened in your assessment?
Yeah, so the IUDs typically don't, the IUDs affect your periods. If you have a progesterone IUD, it will often affect, you may not bleed or you bleed very lightly. It'll affect your bleeding pattern typically, but it doesn't affect your ovaries. Most people with IUDs, progesterone or copper, still ovulate and there's no sort of suppressive effect on the ovaries. So it doesn't impact the assessment. It doesn't impact the stimulation of the ovaries if you decide to stimulate them. The birth control pills, you can still get a sense of where you are, but if your egg numbers are low, we'll sort of say, hey, it could be low just because they're low, or it could be low because you're on these birth control pills. So sometimes people will opt to take a break and reassess to see if they get a rebound in their egg numbers after stopping. If you're doing a treatment that involves stimulating the ovaries, we typically recommend that you stop the birth control pills for at least a month, sometimes up to 3 months, because again, you get a more optimal stimulation of the ovaries when they're not quiet.
Awesome. I know, Audrey, you received a few questions. Go ahead, jump in.
Yes. So one of these questions, Dr. Meredith Bauer, is in an assessment, is that where I could check how fertile I am and if I should freeze my eggs now? So again, just kind of bringing it all home. Is that the best step?
Yeah, definitely. I mean, I think it's a really important step because I won't be able to tell you if you're fertile exactly, right? So the only true way to know if you're fertile is for you to go and try to get pregnant. But we can get a sense of your egg numbers, okay? And that can give us an idea of the sort of the length of your reproductive window. It can give us a sense of how you might do if you did decide to do egg freezing, right? So we can start to make predictions. Oh, if we stimulate your ovaries, you might get 5 eggs or you might get 25 eggs, right? Because we see the whole spectrum of that. And then certainly just getting even more information than what I've given you today about the pros and the cons and where you actually fit into this in terms of prognosis for you as an individual and sort of these treatment plans and deciding whether you need to do it, and do you need to do it now or do you need to do it in a year, often depends on your reproductive goals. It depends on your age. It depends on your ovarian reserve. How many children do you want? Do you have a partner? Are you going to be trying to get pregnant in 6 months, or you have no idea? You might not be trying to get pregnant for 6 years. So we need to take all these factors into account when sort of trying to come up with the best plan for you.
Thank you. And then another question is, what if you are taking depression pills or dermatology treatment? Is there any way to do fertility treatment and keep taking these, or do you need to be completely clean?
Very good question. So I'd say at least half of our patients are on some form of an SSRI or SNRI or something. So you do not need, even if you're trying to get pregnant, honestly, certainly for these treatments and even in getting pregnant, you don't need to stop those medications. So for treatment, for preservation cycles, I would say we pretty much never stop those medications. There's a few exceptions. Adderall is one that we may stop, but straight antidepressants we're typically not stopping. And as I said, even in patients who are trying to get pregnant, we just sort of weigh the pros and cons of continuing versus stopping. And oftentimes we will still continue. Now the dermatology medications, most of those are fine. There's a few dermatology medications that are actually hormone modulators. So something like spironolactone is an oral medication that's sometimes used for skin. That's something that we might have you stop. Almost all topicals are okay. Accutane is not. So it depends on the medication, but the vast majority of dermatology medications, with the exception of just a couple, are okay.
Thank you.
So just to let you know, like how quickly we act on our side of things, I was just touching base with our genetic screening company. I was like, do we check Batten disease? Tell me right now, I need to know. And so I believe, and I want to ask, is it neuronal? And I apologize for the pronunciation. Neuronal ceroid lipoglycan. Oh my gosh. Meredith, this is why you make the big bucks.
Put it in the chat. I'll try to say it out loud.
Yes, exactly. No, I don't want to say it out loud. I know. It's called supercalifragilisticexpialidocious. No, but we absolutely do check that. That is part of our genetic screening panel. So I just wanted to make sure, and again, it's a testament to our team that we really sync and work together to make sure that we can provide holistic care. And on that, my last question was what are your thoughts about acupuncture and fertility treatments?
Yeah, we have acupuncturists as part of our team. I mean, not necessarily at Kindbody, but certainly within each site. I know we all have acupuncturists that we trust and our patients see. So I think that there's certainly a role for acupuncture for many of our gynecologic problems and for many of our fertility problems as well. It's not mandatory. Some patients love it. It's a good acupuncturist not only does needling, but counsels on diet, provides supplements, and provides support. So a lot of times a really good acupuncturist really becomes a part of the support network and is really helping from a very holistic approach. And I think that that's often helpful. I have patients that hate acupuncture. They don't like getting there. They don't like parking there. They don't like to be needled. And for those patients, I tell them that you don't need to do it, that there's not necessarily some evidence that it dramatically changes something, that you should force yourself to do something you don't enjoy doing if it's not something you like. But it is something that we keep as sort of in our toolbox for sure.
So just for clarification purposes, I received another question is, if you have previously frozen your eggs, do you only have one shot to use them? So if you can kind of clarify that process.
So yes, so when you use them, you'll have to decide how many you want to thaw at a time, right? And you may choose, but you only get one shot. So if let's just say you did amazing, you had 20 eggs frozen, you may decide to just thaw 10 and see how it goes, okay? Or you might decide to thaw all 20. But once you say go, you thaw them, you attempt to fertilize them, and that's it. That's that one chance. So once they're fertilized, then assuming they survive the thaw, assuming that fertilization occurs, then we watch those embryos develop over 5 or 6 days to see if any of them develop from being a single cell to being a 200 cell embryo called a blastocyst. And then that is what ultimately is transferred back into the uterus. So as far as one shot, yeah, I mean, you may thaw them in groups, you may thaw them all together, but it just happens once, and you'll see how many embryos you have at the end. And if you may just transfer one. If there are more embryos beyond what you want to transfer into your uterus, so say it goes really well, you have 5 embryos, you may just transfer 1 embryo into your uterus. Everything else gets refrozen. Okay, so if there are extra embryos beyond what you're transferring to the uterus, that gets refrozen. And those embryos then are frozen until you need them. So if the first one didn't stick, or if it's for a future child, then at that time you would just thaw that embryo, and the same day that embryo would be transferred to the uterus.
So I think that's all the questions that I have, but do you have any other, Audrey?
Nope, that rounds it out. I think Dr. Meredith Brower really covered it all.
Yeah.
Super helpful.
If anybody, I think but thank you everybody. We really appreciate you coming today. And we know, and again, you can always ask, like, like Audrey said, you can email us, get signed on, do your assessment, and we're always here to help support in any way that we can.
Yeah, thanks for signing in, everybody.
Thank you all for joining, and feel free to reach out to us at employeebenefits@kindbody.com, and we'll follow up with a recording of this session so you have it on hand as well. So thank you so much, and thank you to Dr. Meredith Brower and Kindbody Tracy. Always a pleasure working with you both, and I hope you all have a great rest of your day and a good weekend. Thanks again.